Lessons from Healthcare Organizations on Improving Patient Experience. My name is Dale Schaller, and I will be moderating our session today, presented by the Agency for Healthcare Research and Quality, or AHRQ, CAHPS User Network. Next slide. Our webcast today will cover the following major topics. We'll start with an overview of AHRQ's CAHPS program, followed by a brief summary of what research has shown to be the foundational elements of patient experience improvement. And then we'll move to lessons drawn from 2 case examples of improvement, focusing on, first of all, improving customer service in a health plan, and then improving patient-provider interactions in a large medical group practice. We'll conclude with a few references to CAHPS resources available for improvement, and leaving as much time as possible to field your questions over the next hour. Next slide. Before we begin, just a few of the standard housekeeping details so we all have a really good webcast experience. If you have trouble hearing the audio from your computer speakers, you can just change the audio selection as shown on this slide to have WebEx call you back, and then you can connect through your phone instead. If your computer freezes up during the presentations, you can try logging out and logging back in to refresh the page. And if you need any help at any time during the webcast, use the Q&A feature that I'm going to show you on the next slide. So this is a picture of how the Q&A feature should show up on your browser, although your WebEx screen may look a little bit different. Find the Q&A icon at the bottom right-hand side of your screen and be sure that the drop-down option displays all panelists so that you can ask the question in a way that our team can see it. We'd really encourage you, if you do ask a question, to tell us your name and your organization or role so we have a sense of who you are and where you're coming from. I will say today's session is being recorded and that a replay of today's webcast and the slides will be made available in the near future on the CAHPS site, and we will give you the contact information for the CAHPS site at the end of today's webcast. Next slide. So I'd like to welcome and introduce our speakers for today's webcast. We'll begin with introductory comments from Karen Ginsberg, who directs the Agency for Healthcare Research and Quality's CAHPS program, as well as the Surveys on Patient Safety Culture, or SOPS program. Karen will be followed by Lisa Franchetti, who is Customer Experience Manager at the Neighborhood Health Plan of Rhode Island. And Lisa will be presenting a case study on how to improve health plan customer service. And then we'll have Denise Quigley, a health policy researcher at RAND and a professor at the RAND Graduate School, who is also a member of the CAHPS Quality Improvement Team for many years. And again, I'm Dale Schaller. I've been a longtime member of the CAHPS Consortium, serving as your moderator today. And with that, I'm pleased to turn things over to Karen Ginsberg. Karen?
Hi, everybody. Good morning and good afternoon. Thank you for joining us today. And before we get started, I just want to give you a little context to today's presentation. We typically host about 4 webcasts a year, and we're going to be devoting this year a substantial number of these 4 webcasts, at least 3, to discussing the issue of how to improve quality patient experience using CAHPS data. So we know that this is an important topic to you all, and we want to spend time exploring this with good examples of ways in which patient experience has been improved using CAHPS data. So look for more announcements from us about this through GovDelivery. I'd like to welcome today you all. There are a lot of new users and to the CAHPS program on today, as well as more experienced CAHPS users. So I'm just going to start off for a couple of minutes talking about my agency for Healthcare Research and Quality, and how the CAHPS program and this work fits into the mission of my agency. So can I have the next slide, please? So my agency, AHRQ, is a research and development agency, and what we do is invest in research and evidence that makes healthcare safer and improves quality. We create tools for healthcare professionals to use to improve care for their patients, and we generate measures and data that providers and policymakers and researchers can use to not only improve performance, but also to evaluate the progress of the U.S. healthcare system. And it's important for my agency to push our science to implementation and to get our tools out to you, our users. Next slide, please. So CAHPS stands for Consumer Assessment of Healthcare Providers and Systems. And this is a program to advance the understanding and the measurement and the improvement of patients' experiences with their healthcare. We've been funded for now 26 years, and so we're a mature program of the agency. And you might hear about, if you're a user of the CAHPS products, the CAHPS Consortium. This is the body that is responsible for the technical oversight of the CAHPS program. And it consists of the staff from AHRQ, as well as two cooperative agreements that we fund for Yale University School of Public Health, RAND and RAND Corporation, and our contractor, WestAt. Next slide, please. So the CAHPS program has a very active research agenda that focuses on understanding patient experience, how to measure it, how to improve quality with CAHPS data, and also the best methods to implement surveys. And that's all in addition to the work that we're most known for, which is developing our surveys on patient experience of care. So let me just say a word about the research on the best methods to implement surveys. And traditionally, we haven't made the work that we do in this area an end product in and of itself for our users, but we know that this is very important to you, and we want you to be aware of the work that we've done. So we've set up a web page explaining the work, and we did a literature review, which we hope we will be updating this year, on methods of administration for CAHPS surveys. Thank you. Oh, next slide. Not quite done yet. The CAHPS surveys, let me say a few words about those. They are the gold standard for patient experience measurement, and they capture the patient's voice in the development of the CAHPS surveys. We focus on what patients tell us is important to measure. We test our questions with patients. The surveys measure patient experience of care in different healthcare settings and with health plans and with special kinds of programs or conditions. The surveys are all developed using a standardized methodology and research findings, and surveys that adhere to this methodology and the CAHPS design principles in their development and that work with us are eligible to use the CAHPS trademark, which symbolizes that they have adhered to our design principles and standards. So I'm going to switch now to some slides that Dale will present, and he's going to say a few words about the elements of patient experience improvement and what we've learned. So if you could switch to Dale's slides now. And Dale, over to you.
Yeah, great. Thank you, Karen. So before we get into the case studies, I just want to briefly set the stage by highlighting a fundamental conclusion that was reached by a team of CAHPS researchers almost 2 decades ago, based on an evaluation of a quality improvement collaborative with 8 medical groups in Minnesota that was convened over a period of 18 months back in 2003 and 2004. The conclusion was that, and I'm just going to read what's on your screen, small measurable improvements in patient experience may be achieved over short projects. Sustaining more substantial change is likely to require organizational strategies, engaged leadership, cultural changes, regular measurement and performance feedback, and experience of interpreting and using survey data. So this fundamental observation that you can make small improvements in some specific aspects of patient experience, but that to sustain larger improvements over time, you need to really address organizational changes in leadership and culture and the systematic measurement and feedback of data. That's been borne out over and over again over the last 20 years in the research literature that looks at case studies and expert reviews of high-performing healthcare organizations. Next slide. And the research has consistently identified about a half dozen foundational elements or key factors that are critical for a healthcare organization to achieve and sustain high levels of patient-centered care over time. And the first, maybe most important, is leadership and governance commitment at the CEO and board level to a strategic vision that embraces the importance of patient experience. True partnerships with patients and families at multiple levels is important, including policy and planning, the co-design and co-production of improvement and redesign efforts, and of course, at the level of care delivery between patients and their providers. A third factor is a strong focus on the workforce that embraces the importance of recruitment and training and the recognition and rewards for all employees, recognizing that positive patient experience is directly tied to positive experiences of the clinicians and the staff that serve them. The next is systematic measurement and feedback, using a combination of quantitative survey data and qualitative methods to assess experience that enable you to provide routine metrics for monitoring and improving performance. And finally, supportive technology and infrastructure such as patient portals, now more than ever telehealth services and decision support tools, and a built environment that's not focused on amenities, but structural elements such as wayfinding and noise reduction and access to light and natural elements to create a healing environment. So not all of these elements will be covered by the case studies that our speakers present today, but we wanted to highlight them as context for the case studies that they will present. And so with that, let me turn now to Lisa Franchetti for our first case study. Lisa?
Hi, Dale. Thanks so much. Good afternoon, everyone. So thanks to AHRQ for inviting Neighborhood to share some of our lessons learned regarding how we have been able to improve our CAHPS scores. My case study is focusing on the health plan CAHPS surveys specific to the Medicaid adult population. So I'm the customer experience manager in the marketing department here at Neighborhood, and I've been working with CAHPS survey data for over 20 years, loving every minute of it. And 18 of those years are here at Neighborhood. Next slide. So today I'm going to share how our CAHPS survey results fit into Neighborhood's quality improvement efforts. I'm going to walk through some of the common challenges we faced and explain how we identified an improvement opportunity. I'll also share some details of the interventions our member services department has implemented. And then I will close out my presentation by sharing some results and ongoing QI efforts we have planned going forward. Next slide. So first, how does CAHPS fit into Neighborhood? Currently, Neighborhood serves over 204,000 members. That's 1 out of 5 Rhode Islanders. And about 109,000, or 53% of those folks, are Medicaid or dually eligible adults age 18 or older. These Medicaid adults include 4 distinct populations: traditional low-income parents, Medicaid expansion adults, adults with disabilities, and dual eligibles. Our Medicaid line of business has achieved excellent accreditation status from NCQA for 19 consecutive years, from 2001 through 2019. Most of the health plans, so we are aware that the accreditation process has changed a little bit in 2020. So before 2020, we used the Health Plan CAHPS Medicaid Adult Survey results for our annual NCQA health plan rating and for CAHPS accreditation scoring. Our CAHPS results are shared with several internal committees here at Neighborhood, such as our member advisory committees, which I'm very proud to say continue to meet virtually. We also share them with our Quality and Operations Committee internally, our Clinical Affairs Committee, which includes several physicians, and then finally with our state partner, the Rhode Island Executive Office of Health and Human Services. In short, there are lots and lots of eyes on CAHPS up at Neighborhood. Next slide. So Neighborhood faces challenges that are common to many, many health plans. They include increasing CAHPS benchmarks. So we use NCQA's Quality Compass benchmarks for Medicaid. And as we all know, as health plans improve, the goalposts shift and keep us on our toes. Growth. So from 2013 to 2016, Neighborhood doubled its membership, added new lines of business, and we also doubled our staff. This introduces training and resource challenges along the way. Technology. So I don't know how many systems your organization is using, but we use many. And whenever you have many different systems, that increases the number of data points you need to track. And then finally, research challenges. CAHPS for the health plan is a single annual point-in-time data collection that typically only scratches the surface, but in a very important way. It requires validation against other data sources, which we've always done. We look at member complaints or call log data, as well as supplemental drill down data. The collection of all of that supplemental data can pose resource and budget challenges that you have to commit yourself to. Also, our CAHPS response rate has steadily declined from a high of 43% in 2003, which I would yearn for right now, or it's declined to 21% now in recent years, causing us to oversample. We are committed to oversampling. We oversample 150% for Medicaid adult, and we'll continue to do so in order to make sure we have actionable data at the subgroup level. Next slide. I know this is a busy slide, but it's my favorite slide. I love this slide. So Neighborhood's approach to CAHPS improvement opportunity identification is to focus on what we can impact and measure. This graph says a lot. It displays our Medicaid adult customer service composite score over time dating back to 2008. So the orange line is our Medicaid Quality Compass 90th percentile, which climbs. The red line is our overall Medicaid adult performance, which has been variable, as you can see. The other lines represent all our different Medicaid adult groupings or lines of business, and each is very different by age, gender, and illness burden. So our survey vendor, we use SPH Analytics, they do correlation analyses that continue to show customer service is a key driver of our rating of health plan. So it's vital that we do well. It's vital to the mission of Neighborhood. We remain absolutely committed to providing the best quality customer service possible. In 2016, something not so great happened. So our customer service composite fell to the 10th percentile. That was completely and totally unacceptable. We dug in, and because we had actionable subgroup data, we were able to target interventions. We were also able to add a corporate goal as part of our strategic plan to improve customer service. We've been able to maintain our gains since 2017, and now I'm going to tell you how we did it. Next slide. So after the 2016 results, I was in quality improvement at the time, and I recall the day when we ran over to member services and we had a chat. So we knew that we needed more data to understand what was happening with customer service. I'll be really clear right here. So customer service at Neighborhood really involves every single member-facing department. Yes, our member services call center area handles the largest volume of direct member interactions, but it's not the only one. However, what we've always known is our member services department, if you want to turn the dial up and make rapid improvements and follow your Plan, Do, Study, Act cycle, our member services management team are the best there is when it comes to jumping whenever we need their help. So we needed actionable and timely information. So we did a supplemental weekly IVR, interactive voice recording. We did robocalls, and we repeated that for 4 years in a row. What was it? It was a 3-question automated IVR survey. So we asked members to rate on their phone, rate the courtesy shown by the representative, the information received, and the overall experience with the health plan on a 5-point scale, where 1 equals poor, all the way to 5 equaling excellent. So when did we do this? We did this off cycle from CAHPS. So CAHPS, we know, is springtime, March through May. And so we did this between August and January. So we do this off cycle to reduce survey fatigue. How did we do it? This was not originally budgeted. This happened right in the middle of the year, but I was able to maximize our existing nurse advice line contract, which included thousands of unused outreach attempts. And we were able to use a template survey. All we had to do was plug in our plan name. And so this was able to get up and running very quickly. So we surveyed about 800 members weekly, and at first we had a 20% response. We surveyed over 21,000 members the first year, over 4,300 responded. And the challenge has been, of course, declining response rate over time. But what would happen? So each week I would send an Excel file via a secure FTP site, get it back the following Monday with the results. And then I reviewed the results in Excel, made pivot tables, and I shared any of the poor rated calls, all of those ones. I shared those with our member services quality analyst, and she would substantiate them. So we had 191 calls rated poor. I'll tell you that first year, 59 of the 191 were substantiated as true poorly handled calls. The major point here, the aha moment for all of you today, is that I, as a CAHPS analyst, I listened to the poor rated calls. I was at Neighborhood for 16 years and I had never listened to an actual call. Listening to those calls added a level of detail, emotion, and urgency. It was transformative. And so we were able to jump into action and turn the boat around. We validated that we needed to make improvements in our training process, and we did. Next slide. So some of the interventions, these are just a few. So the big aha moment here again is that you need to do more than one intervention. It has to be a multi-pronged approach. So what did we do? Customer service, of course, is 100% within the health plan's control. What we found is that new hires surveyed after 30 days, when we reached out to them, they identified the need for additional pharmacy and benefits training. So when we got the results, we went back to member services. They took the results, they pulled everybody together, the supervisors, the entire staff, and these are what they came up with. We set up a feedback loop between the quality analyst and the supervisors and member services. Supervisors began monitoring 1 call out of the 5 per rep per month as we needed some stronger oversight. We modified our call monitoring tool and scoring sheet, so any calls that were handled rudely automatically received a score of 0. We also realized one of the big things was offering the complaint process to dissatisfied members. We have a strong member advocate at Neighborhood, and we needed to reinforce the member advocate training throughout the other departments to increase and reinforce awareness of that resource internally. The other thing that it pointed out was getting care quickly. So getting care quickly, how satisfied are members in getting appointments for urgent and routine care? A lot of health plans think that this is 100% the responsibility of the provider network and health plans cannot impact. That's wrong. Health plans can absolutely impact satisfaction with getting care quickly. Part of what we learned is that the way we were answering member inquiries about provider availability. So our staff was using an internal cheat sheet. And you know what? If you direct your staff to use the same exact online provider directory that members use, you will immediately find anything that needs to be updated. We found the urgent care center search functionality was not working, and we got that corrected. We also implemented a provider directory generator. No one wants to send a giant print multi-100-page PDF to a member. If a mom is calling and she just wants the list of available pediatricians in her hometown, let's just send that. And so we created an internal resource to do just that. And then we also began collecting and storing member emails. Then we also implemented a new JIRA process. What's JIRA? That's a ticketing software. So this way our member services staff could submit any needed updates that could be within a software platform that could be tracked. Instead of emailing different departments with needed updates, it's very hard to track emails. A JIRA ticketing process is much better. Next slide. So let's go over some of the results. We saw results quickly. How do you see results quickly? You do a lot of interventions. So we were able to see a significant improvement within a year from 2016 to 2017. If you see that asterisk, treating members with courtesy and respect improved significantly from the 10th to the 95th percentile in 1 year. And we've been able to maintain those gains. In addition, getting help and information you need from customer service also increased, and the overall customer service composite increased from the 10th to the 75th percentile. We actually achieved our highest ever customer service score in 2020, that 91.86%. We are super proud of that. So you can see our customer service improvements have held and grown through 2020. One of the big reasons is we've continued to always do that supplemental data collection. We didn't just do it for 2 years and stop. It is now a key maintenance activity. Next slide. Rating of health plan. So customer service has been a long-standing key driver of rating of health plan. They are intrinsically linked, and all of us at Neighborhood are committed to making sure we deliver the best service possible. Rating of health plan had been worth double accreditation points for years and years, and is still included in NCQA's health plan rating methodology. So members rating a health plan a 9 or a 10 are considered the most loyal and likely to promote the health plan to family and friends. So our 9+10 score has remained high and in the 90th percentile for 16 consecutive years. We're very pleased about that. It also tracks very closely with Net Promoter Score. We started measuring NPS in 2018 with a custom question, and we are thrilled that we have an NPS of a +69. Next slide. So there's never any rest in quality improvement. It makes life fun. So we know that in order to hold our gains, we must continue measuring, tracking, and improving wherever we can. We repeated the supplemental data collection through January 2020, and then we realized, we need to take a deeper, more foundational approach. We completed our first ever Medicaid member journey map in 2019 as part of our development and commitment to a new customer experience program. We also developed a new set of brand promises in 2020. We had an aha moment in February of last year where we realized, our customer is no longer only members. Customers are members, providers, and employees, and they are all equally important. That rating of health plans, 16 consecutive years of success, cannot be sustained unless and until we commit the same level of energy and dedication to making sure our providers and employees are as happy as our members. We also decided to switch away from robocalls to do text messaging. We started doing that in October 2020. We switched the cadence of our measurement from weekly to daily, and now we have an analytic dashboard through Qualtrics. We're also dedicating ourselves to deploying Salesforce, the CRM, the Customer Relationships Management software in 21, to ensure staff can efficiently access information and enable first call resolution. This is all the technological voice of the customer foundation we need to continue to innovate going forward. And we're getting closer to first call resolution. We're getting there. Next slide. So lastly, some of the lessons that I've learned and we've learned as an organization. It reinforces everything Dale and Karen shared earlier. So our annual health plan CAHPS surveys scratch the surface, and identifying opportunities and supplemental data collection is always necessary to target those interventions. Oversampling, I'd never understand health plans who don't oversample. Oversampling is a must. We oversample 150%. It's a necessity to make sure that we have actionable CAHPS results at the subgroup level. Health plans can impact more than customer service and rating of health plan. You can do it. Strong cross-departmental relationships in an organization are a key to success. Everyone I work with on a daily basis, a lot of us have been with Neighborhood for almost 20 years each. We're not only respectful colleagues, we're friends, we're responsive to one another, and we're all equally dedicated. That next bullet, CAHPS analysis leads should listen to actual member calls. Don't just sit with your Excel data and your SAS data. Make sure you listen to those calls. It will give you insight you are missing and you don't realize it. And then lastly, start somewhere in your journey to achieve first call resolution. Don't wait until you can do an immediate after call survey. There are other things you can do. Next slide. So that's it. So I'm Lisa Franchetti, the Customer Experience Manager. You can reach me via email at lfranchetti@nhpri.org, and my personal phone number is 401-459-6092. Thanks.
This is Dale. I want to just add my thanks to that presentation, Lisa, and we'll have time to come back for a Q&A. couple of questions have already come in, but let's move over to Denise right now. Denise, why don't you take it away on your case study?
Thank you, Dale. Hi, good afternoon, and my name is Denise Quigley. I first off want to thank my team at RAND. Our work is not done in a singular fashion. I'd like to thank Mark Elliott, Mary Slaughter, and Ron Hayes for their participation also in our partnership, and also our partner AltaMed. Today, I'm going to talk about our work on improving a patient experience with AltaMed's shadow coaching program and also their pay for performance incentive efforts, all that were aimed to improve their patient-provider interactions. And they did this by using the clinician and group survey. So next slide, please. So the context at the start of the project was that we knew, and so did also AltaMed when they were looking into what to do. They knew from the literature that shadow coaching is effective for providers. That was shown for different types of providers, which was key for them. They wanted to make sure that they included all providers in their efforts to improve patient experience scores. And so from the literature, they had seen that shadow coaching could build and maintain competencies with medical doctors, but also with nurse practitioners and medical assistants. And they also had seen literature where shadow coaching was able to increase compliance with practice guidelines. So they were key on maybe trying shadow coaching. It's also true that they knew at the time that providers' response to pay for performance efforts with incentives was unclear, and that the evidence was mixed at that stage as well of whether incentives really could improve provider behaviors and or patient experiences. Next slide, please. So who is AltaMed? Well, AltaMed is a large urban federally qualified health center that's in California. They have 44 primary care clinics, and they see about 1 million patients annually. They started using their CAHPS, CAHPS, clinician and groups CAHPS survey in 2012. And it is true that their aim was to improve patient experience. They knew that they needed to identify and target modifiable provider behaviors to be able to improve the patient experience. And they moved then to administer the clinician and group survey. They had the Press-Ganey survey previously, and so they did include some custom questions on their survey to be able to trend their Press-Ganey items over time. In October of 2014, they got a new chief medical officer. And when he came in, he decided to implement an incentive program to pay the providers for their performance. They based these incentives on the clinician and group survey. And what they used was a 6-month average of the score of all of the patient experience surveys that came in over that 6 months on the one item of the overall provider rating. And that was scored on 0 to 100, even though in the survey itself, it's from 0 to 10. And they did that every 6 months. Next slide. So when they started the incentive program and were paying out to their top providers, so everybody who received a 90 or above on that 100-point scale for the overall provider rating, they also realized that they were identifying what they call medium performers, those providers that did not meet the 90 on the 100 scale on the overall provider rating during that 6-month period. And they wanted to understand how they might be able to have the medium performers improve their patient experiences to be able to raise their overall patient experiences. So their discussion started on how they could do that. And they wanted to be able to use the clinician and group CAHPS survey, since that was the basis also for their incentive program. And so as what they did is a pilot in 2015 and 16 with a small number of providers. They did use for their coaches the high performing providers. They used 2 of them for the pilot. And they had those high performing providers also discuss best practices that they were using. And then they initiated a shadow coaching program. What that is that they had the coach or that high performing provider on the CAHPS scores to shadow and observe a provider for a half to full day during their actual patient visits. That allowed the coach to observe the interactions of the provider being coached with their patients. That usually ended up being between 4 and 8 patient visits, so that they could see how the provider interacted with multiple patients. Immediately after the half-day or shadow coaching, they did have a verbal debrief. And then within a day or two, they wrote up their recommendations in a written report that came from the coach to the provider only. And it focused on goal setting and personal improvement and gave them recommendations on how they could improve their interactions with their patients. So they did that as a pilot in 2015. And then in 2017, they went ahead and implemented this across all providers. So what they found is that about 30 providers were identified every 6 months that they did as they were identifying for incentives. They identified those medium performing providers that could be eligible for coaching. And they coached around 98 coach providers when we first talked with them. So next slide. So we came alongside them and partnered with them in the middle of 2018. And our study objectives with them was to evaluate coaching and if it improved patient experience scores, to also evaluate incentives and if that improved patient experience scores. And they were also interested in recoaching. So if they would coach a provider that had already been coached before, and if that had any different effects than the initial coaching. And that's actually planned for this year. I'll speak of that a little bit in a moment. But next slide, please. So the evaluation study design that we talked to them about was to analyze the patient experience trends from the CAHPS data, comparing the coached and uncoached providers, and also to analyze the influence of their pay-for-performance incentive payments. They did discuss with us the fact that they needed more sophisticated modeling and trending. They did talk about the fact that they used CAHPS to benchmark for each of their individual providers, that they used that for the coaches in identifying best practices. They also used CAHPS, as I've spoken of already, as their quality measure. But that data, the quality scores, were also used in one-on-one counseling with providers, and the providers knew that it was attached to the incentive program. That, of course, was really the basis for their shadow coaching program. But they really weren't sure of the overarching impact of how it was impacting the patient experience trends for an individual provider. They had coached the 98 providers, and so we talked with them about an analysis strategy for being able to do that. We also were able to talk to them about how we could potentially design an evaluation that would look at recoaching. So what we were able to do is when they calculated their 6-month average scores at the end of 2018, they again identified an eligible set of medium performing providers. At that particular time, it was 39 providers. So they did that identification of those eligible providers for coaching as usual. We then used a waitlist control design to assign the recoaching. So of those 39 providers, we did have data on their overall provider rating score from the 6 months previous, which is how they got identified to be eligible. And we also knew, of course, their provider type, meaning were they a doctor, a nurse practitioner, or a medical assistant. And given that they did always include the full range of their provider types in their coaching program, we went ahead and used those two variables, the CAHPS performance on the overall provider rating and the provider type, to stratify the random sample assignment. And we were able to then randomly assign 20 to be recoached and 19 to be controls. Today, I'll be able to mostly share with you the information around analyzing the CAHPS patient experience trends and also the incentive payments. The recoaching of right now is still ongoing, so I won't be able to discuss the outcome of that today, but maybe in the future. Next slide, please. So for the analysis, this is the data that we had in conjunction with AltaMed. They provided to us data from July 2012 to June 2018. That was, as you can see here, roughly the 46,450 completed surveys for both child and adult surveys. That's what we are going to present today and what we had in terms of the initial analyses to look at the impact of coaching. The second phase is to be getting the second wave of data up through, in the end, through to 2021, and we'll be able to use that data to evaluate the recoaching. We were also able to gain from them the incentive payment data for 2 years, for 2017 and 2018. Next slide, please. In addition to the data that they had collected administratively, we also, for part of the evaluation, decided to collect additional information on provider perceptions and also to analyze the coach feedback reports that the coaches provided individually to the providers. So we administered a provider survey. We did that to all providers, and we did that in August of 2018, and we did it again in January 2020. Today, the results that I can talk to you about will be the one from August of 2018. As part of the evaluation for the recoaching, we also gave a survey with the same survey with a couple additional questions before and after recoaching for those that were in the recoaching program and also those that were the controls. Additionally, we conducted interviews with providers that was after the recoaching, and that was done in July through August of 2019 for both the controls and the recoach, so for our full set of 39. Today, though, I will be able to talk to you also about the content of the coach feedback reports that contain the recommendations that were made by coaches to providers. We have 92 coaching reports, and that was over the entire period of time. So I'll be able to tell you what those contained. Next slide. But first off, and maybe most interesting, of course, is how we modeled the patient experience trends before and after coaching. We did do this for two measures. We did it for the overall provider rating score, and it was scaled from 0 to 100. We also did that for the provider communication composite, as it is known that the provider communication composite is highly correlated with the overall provider rating and it is one of its main drivers. But it's also true that that was one of the main behaviors that was targeted for the coaching. We compared the coached providers to uncoached providers before and after coaching. We're able to do that with a statistical analysis that's called spline modeling. What that is basically is it looks at the slope of a trend line before and after an intervention. And so it forms a knot in the line where it can bend at that knot, and that knot is typically at the point of the intervention. We also modeled that to see if there was an immediate effect of the intervention with a possible what they call a jump, so a disconnected two sets of slopes at the actual coaching date. So meaning that immediately after coaching, when the provider went back into their patient visits, they changed behaviors, and that was identified on the patient experience surveys of those patients who interacted with the provider after the coaching. We ran those models and we were able to adjust for patient characteristics that are listed here, the site, the clinic site that they provided medical care at, and also a random effect for the provider to try to control for any differences in the providers themselves in terms of characteristics. We did use the actual coaching date for that knot for the intervention. Next slide. So just to summarize what we saw on the slides, we do see that coaching improved patient experience, but we see that it faded over time. We did see a small to medium-sized jump of 2 points across both of the measures. We also note that the uncoached providers didn't change as expected. But that we saw these improvements, these gains in scores did fade about 40% a year, and they went completely away after 2.5 years. So we do feel it's important as we move into the next phase to assess the recoaching effect, see if it also has the same jump, an immediate effect, and if it also erodes or if it can help with diminishing the erosion. So based on what we know though so far, we've been discussing, and also with AltaMed, the fact that they would have coaching boosters, and they're thinking about that as a regularly planned annual booster of the coaching to maintain the gains in the scores. Next slide. We did a similar analysis to evaluate the influence of the pay for performance incentives. We modeled the trends for the two CAHPS measures as before, and we did the same comparing of coached and uncoached providers before and after the incentive existed. And we did the same spline modeling with the same types of adjustments. And in the end, we saw that the incentives had no influence on the trends of either of the patient experience measure. Next slide. It's also true that we saw through the surveys that coaching increased the desire to improve and to provide tangible feedback. We saw that in their desire to improve their behaviors, in specific behaviors, interactions, communication with care team, and also coordination. And then we saw it in what was provided in terms of tangible recommendations for communication. Next slide, please. In the content of the recommendations in the reports, we saw that half of the recommendations encouraged existing behaviors that the providers were interacting with their patients. And the other half of the recommendations actually were identifying new behaviors for the providers to try. The recommendations did map to the behaviors that are identified on their CAHPS survey and also the Press-Ganey survey. I've listed them here. For example, in terms of engaging and spending time with a patient, which is a CAHPS item, the recommendations would point out to sit with the patient at the start of the encounter, to not stand by the door, to position themselves between the computer and the patient. And in terms of listening, for example, they would have recommendations around the provider asking for a primary concern from the patient or letting the patient speak for a minute uninterrupted. Next slide, please. We did find out, though, that the providers wanted more support. They did feel that they wanted even more actionable input on several of the items around listening and being friendly and having a relaxed demeanor. They also indicated that they wanted additional coaching and training on certain types of patients, as listed here, and also 2 different types of clinics. Next slide, please. So they also talked about the things that they needed in terms of improving patient experiences. They did identify that time pressures during patient visits limited their ability a lot of times to develop good patient relationships. They pointed out needing tools and best practices to communicate with patients around test results or to discuss best practices with other providers. It's also true that overarching, when they were asked about the quality monitoring system, they did indicate that they'd like to have more of a focus on improving all of providers' perceptions on CAHPS' ability to reflect patient experiences, which primarily came from or stemmed from their talk of low response rates. They indicated the need for more QI training and also comprehensive leadership across all clinics and within the organization as a whole. Last slide, please. The lessons learned for this particular partnership with AltaMed and their shadow coaching and incentives were that they did use CAHPS as a benchmark. They did measure change in terms of provider behaviors. They also used CAHPS as a tool for counseling individually with providers and, of course, as a basis for their shadow coaching. And they also had the CAHPS measures integral in terms of supporting the recommendations from the coaches to the providers on the behaviors that needed to change. Providers indicated that there were definite needs that they had, and they still wanted tangible and actionable recommendations. And they wanted specific tangible behavior recommendations around certain interactions that they had with their patients that they needed to be able to work on. There was a focus, of course, as well for the project on incrementally improving the culture in the system. They marketed their efforts to all providers. That was through both the incentive program and the shadow coaching program. And there were several ways that they talked about needing to gain buy-in from the providers. They needed to gain buy-in on the value of patient experience data. They needed to provide information on the shadow coaching program itself and making sure that there was buy-in to that program so that people would put their best effort forward in terms of making improvements. They needed provider buy-in in improving behaviors that they were interacting with their patients. And also in terms of the data collection, they needed to be able to have that what was linked to the evaluation. We needed to have provider buy-in to answer the surveys and participate in the interviews. Ultimately, what AltaMed has walked away with is that their shadow coaching needs to be embedded into their long-term professional development. And they are working on that and hoping to find out more about the recoaching to think about how that will be able to be embedded and at what frequency. That's all that I have to share with you today about lessons learned. Next slide. I want to thank you. My name again is Denise Quigley. I am a health policy researcher at the RAND Corporation. You can reach me by email if you need to at quigley@rand.org. That's QUIGLEY@RAND.org. Or through my phone number at 310-393-0411, and my extension is 7549. I thank you for your time today.
And Denise, I thank you for an excellent presentation, and Lisa as well. You packed a lot of content and information into less than an hour. I want to move right to some questions. I'm sure the two of you will be getting some follow-up questions given the contact information that you've given out. But let me first turn to Lisa. There were a couple of questions that came in during your talk. One related to the IVR calls and whether the respondents that were asked to participate were included immediately after the customer service call, or was it a separately administered robocall at a different time after the member contact?
Yeah, hi Dale. It was definitely the latter. So it was not immediately after the call. We hope to get to that point at some point later this year, but it's after the call. The first set were anywhere between 1 to 7 days after the call, and what we're doing now is within 24 hours of a phone call.
Yeah. And then you mentioned too a transition between IVR and SMS. Can you say something about how that may have affected response rates and the demographics of those who are responding?
I can definitely speak to the response rate. So we just started doing it last October, and we are concluding it this week. The response rate has declined from 10% for IVR for the robocalls to an average of 4%. However, I'll take the trade-off because we end up with timelier data, and we have been able to respond immediately or as fast as we can. It's a difference of 24 hours to respond to a member need versus up to 3 weeks the old way we were doing it.
And one more question here quickly before we move to a few for Denise. Can you say a little bit more about the feedback loop that you put together between the quality analyst and what you call the CC supervisors?
Sure. So that is a formal, documented, structural process where the quality analyst would pull the call recording in question, review it, substantiate if it was a call needing work, and the quality analyst would go through the Qualtrics dashboard and actually provide recommendations for any of the staff retraining needed. And that would go directly to the supervisor. The supervisor would then speak with the representative and then close the loop within the Qualtrics dashboard. It was all documented, so the quality analyst would know it was done. And then the nice thing is in Qualtrics, we can measure all of the retraining and figure out if it's an individual representative issue or if it is a department-wide issue. And so far, it's just been individual representative issues.
Great, thanks, Lisa. So Denise, a couple of questions that are sort of related to the metrics that you used for evaluation. Can you say a little bit more about why using a 100-point scale? And secondly, on the overall rating, did you use the mean score or the top box, and which one and why?
Thank you, Dale. So the 100-point scale is to rescale from the 0 to 10 to the 100-point scale. It just allows being able to look at the variation. I think that's relatively standard. That's also, so the 9 and 10 top box ends up turning into above 90. So that's why it's just rescaled. That also, when you can rescale the composites, for example, with CAHPS, it's for the same reason. If you rescale them to 0 to 100, then everything is on the same scale. And so when they did the provider communication composite, that they used the standard CAHPS ability to make the composite score from the items that are around the provider communication, and then it also then gets translated to the 0 to 100 score. Did that answer the question?
I believe it does. Thanks so much. And then another question related to the P4P, Pay for Performance Incentive Program. Question is, how was it funded?
Well, that is a good question. I am not sure how it was funded. I know that AltaMed has money that they set aside to use for the incentives, but I am unsure exactly how that is funded. I've never asked them that question, and we don't have Ephraim Talamontes, who is the Chief Medical Officer, on today to ask that specific question. Okay.
Maybe we can get some further information about that out to the questionnaire. So one other question related to the coaching program is what methodologies were used, and was it, who was actually doing the coaching? Was that internal to AltaMed, or was it an external service that was brought in to do that?
Good question. They did actually read a lot of the literature at the time, and there are different ways to set up the coaching. They did follow the recommendations that is found in the literature that indicates that you should be using both a debriefing immediately after the coaching and also a written report that follows up. So that is standard in the literature that it's good practice as a coaching model. They decided to use internal high-performing providers. So they selected, actually crossed their provider, the ones that were high-performing providers over time. They selected 8 of them. They also felt that they should be geographically located in different areas because of how spread out AltaMed is, and they wanted to make sure that they were representing all of the various clinics. So they did select the 8 coaches from across all of their sites, not just from a site. They did also then have a one-day training session where they brought in an outside expert on communication and had them talk about various recommendations. That's also the case where they pulled in their own individual provider scores and discussed best practices that they were individually using as providers in their own practice, and they discussed that up front. A lot of that was what was done during the pilot, was developing the content sort of the program. They were already doing the incentives every 6 months, so they decided that that's the window that they would be using the coaching, that every 6 months they would go ahead and piggyback off of the selection process that you could do at different intervals if you were setting up your own program. So they didn't service to an outside. They felt they needed the cultural knowledge of the actual providers, their own high-performing providers. So that's why they did an outside person to come in to train the coaches themselves. And then they ended up also feeling that they had better buy-in if there was a coach and it was your own peer as a peer coaching model versus from the outside.
Right.
So most of their direction from that was taken from the literature.
Great. Thanks so much. And we're going to have to move right now to just wrapping things up. If I could have the next slide. Just a quick reference to improvement resources available on the CAHPS site. We have what we call the CAHPS Ambulatory Care Improvement Guide that's available, along with reports and case studies at www.ahrq.gov/CAHPS. Next slide. We will have 2 additional webcasts coming up this winter in February and March, 2 yet to be scheduled. And the way in which you can stay tuned for that is by registering on the AHRQ site to receive what are called email alerts. And you find it by going to the sort of page on the AHRQ site that has the email updates in the upper right-hand corner, and then you select that, and then you can enroll in any number of services to receive ongoing email updates about programs and events that the CAHPS team is sponsoring. The next slide will give you just the basic information on how to keep in touch with us by email at caps1@westet.com or by phone at 1-800-492-9261. And of course, the website again is www.ahrq.gov/CAHPS. The last slide is a big thank you again to Lisa, Franchetti, Denise Quigley, Karen Ginsberg for a fantastic set of presentations today. A lot of content. Thank you for offering your contact information that I'm sure people will use to follow up. When we move out of the webcast, you will see a pop-up of a brief evaluation, and please do fill it out because it helps us with the programming that we do in the future. We invite you to visit the AHRQ website often, anytime. And then one final thank you. We're out of time, but thanks to everyone for participating today. Thanks for joining us, and have a wonderful day. Thanks again.